right. Good afternoon, everyone. It is 1 p.m. on the east coast of the US, so it is Easter time. My name is Sigfús Kristinsson, and I'm happy to welcome our in-person and online audience to today's presentation. Before hearing from today's speaker, I want to alert you to our talk in 3 weeks' time, when Dr. Kyriaki Neofito from Johns Hopkins University will present her work on bilateral contributions to word production, evidence from aphasia, and related disorders. The talk will be a week off our bi-weekly schedule, as we'll have a break in the week of Thanksgiving. Today, however, it gives me great pleasure to welcome Dr. Maria Varkanitsa, Research Assistant Professor in the Department of Speech, Language, and Hearing Sciences at Sargent College of Health and Rehabilitation Sciences, and Assistant Scientific Director at the Center for Brain Recovery at Boston University. Dr. Varkanitsa obtained her master's and PhD in neuroscience, language, and communication from the University College London. She trained as a linguist and cognitive neuroscientist, and her research focuses on the neural and cognitive mechanisms that support language processing and recovery after stroke. Dr. Varkanitsa integrates behavioral, neuroimaging, and computational approaches to identify predictors of treatment responsiveness and long-term outcomes in people with aphasia. And her recent work also examines the role of cerebral small vessel disease and vascular brain health in shaping recovery and cognitive resilience after stroke. And today, she'll share some of her work on vascular brain health and aphasia recovery. Please feel free to write your questions in the chat during the presentation for Dr. Varkanitsa to answer at the end of her talk. And with that, I'll give the floor over to you, Maria.
Thank you, Sigfús. Good afternoon, everyone. It is a pleasure to be here and have the opportunity to present our work on vascular brain health and aphasia recovery here at the Center for Brain Recovery at Boston University at this audience. I will start today by setting the stage, a bit of background on how vascular brain health fits into our understanding of aphasia recovery. Then I will move into our studies, where I will share findings from a set of retrospective analyses across independent cohorts. Building on those findings, I will outline a broader framework, how these ideas come together to help us think about recovery mechanisms in a more integrated way. And finally, I will end with the next steps, connecting this work to our overarching mission at the Center for Brain Recovery. So as we know, aphasia is one of the most common and life-altering consequences of stroke, affecting roughly a third of stroke survivors, or more than 200,000 people each year in the US alone. And beyond the language impairment itself, aphasia profoundly affects participation, relationships, and overall quality of life. The encouraging news is that recovery is possible even years after stroke onset. We see meaningful improvements when therapy is well targeted and intensive, which tells us that the post-stroke brain retains a remarkable capacity for reorganization. But the degree to which this recovery happens varies greatly across individuals. And this figure on the right is a schematic illustration, not empirical data, showing that recovery trajectories differ widely across individuals. Some individuals experience substantial gains, others make steady but moderate progress, and some show more limited recovery over time. And of course, a major question is, why do these trajectories diverge, even if aphasia severity or intensity of treatment is similar? And our field has done an excellent job identifying the many components that influence the journey of recovery after stroke. We know that outcomes depend on a combination of factors, like who the patient is, the characteristics of the stroke lesion, the initial severity of aphasia, and the timing and intensity of speech and language therapy. But even when we account for all these, there is still variability left unexplained. And that open space in the diagram represents the missing pieces all the influences on recovery that we haven't fully mapped yet. What I will argue for today is that one of those missing pieces has to do with the broader neural ecosystem in which recovery takes place. The brain's ability to reroute, compensate, and sustain communication across networks depends on the health of the underlying vascular and structural systems. And when those systems are compromised, the potential for adaptive reorganization is, of course, reduced. The natural next step for us was to zoom out and ask, what is the condition of the system that recovery relies on? And that brings us directly to the idea of brain health. And to make this concept of brain health more concrete, the lens I focus on is cerebral small vessel disease because it provides a powerful window into the brain's vascular and structural integrity. So cerebral small vessel disease, or CSVD, or just SVD, refers to a group of pathologies affecting the small perforating vessels deep within the brain. These vessels are essential for supplying white matter and subcortical structures. And when they are damaged, we see characteristic MRI markers, things like white matter hyperintensities, lacunes, microbleeds that I will explain later. Cerebral small vessel disease is extremely common, especially in older adults and in individuals with stroke. It contributes to ischemic and hemorrhagic strokes, but it also contributes to slowed processing and executive dysfunction. Importantly, cerebral small vessel disease reflects the brain's vascular and structural integrity, as I said before, and because of that, it has the potential to influence how the brain responds to injury, including how much recovery is possible, and may also accelerate decline when it coexists with other pathologies like Alzheimer's disease. So given that CSVD is common in stroke survivors and has all these effects on cognition, my working hypothesis is that small vessel disease plays a role in aphasia recovery as well. And of course, I'm not the only one who has thought about small vessel disease in the context of aphasia. In recent years, several studies have begun exploring how vascular brain health might influence language outcomes after stroke. And recently, our small subfield actually got its first systematic review that synthesizes all the evidence. And it was very exciting to see that. But on the other hand, this systematic review highlights how limited the literature still is, featuring only 13 studies, and most of which focus on a single marker of cerebral small vessel disease, namely white matter hyperintensities. And this brings me to our own work. As I mentioned, most studies focus on white matter hyperintensities. We started there, but then we started looking across the small vessel disease spectrum. The first two studies that I will present leverage data from a larger clinical trial examining the neurobiology of language recovery in aphasia. And as part of this study, participants first completed a comprehensive baseline evaluation, which included both neuropsychological testing and MRI scanning. Then they received 10 weeks of typicality-based semantic feature analysis treatment. And at the end of the treatment period, participants returned for a follow-up visit where they repeated the same behavioral assessments and neuroimaging procedures. So a little bit of background about our cohort. We included 30 individuals with post-stroke aphasia. The majority of them were male, right-handed. The mean age was 61 years, and they have an average of 15 years of education. Turning to their stroke-related characteristics, all participants were in the chronic phase of stroke with an average of 57 months post-stroke. each had a single left hemisphere lesion, and we had a good spread of aphasia severity with a mean WAB AQ of 59 and a representation across multiple aphasia subtypes. And as I briefly mentioned earlier, all individuals completed a 10-week program of typicality-based SFA treatment. And the plot here shows the distribution of their accuracy change scores from pre-treatment to post-treatment, which is essentially the behavioral outcome we are trying to predict in the two studies that I will present. Finally, you can see here their performance on the Boston naming test and the pyramids and palm trees test, along with their nonverbal executive function scores, which we calculated based on symbol trails, mazes, and design generation subtest of the cognitive linguistic quick test. We rated 4 individual cerebral small vessel disease imaging markers. We started with white matter hyperintensities. We looked at enlarged perivascular spaces, lacunes, and global cortical atrophy. And I will provide a brief introduction in each of them. Starting with white matter hyperintensities, these are bilateral, mostly symmetrical lesions in periventricular spaces and deep white matter. They appear as bright areas on FLAIR MRIs, and they primarily reflect chronic ischemic injury. In everyday clinical practice, their severity is quantified based on visual inspections, and this is what we did in our studies. We used the Fazekas scale, which is a 4-point scale with 0 reflecting no lesion and 3 reflecting severe lesions. But let me walk you through a few examples of what these lesions look like. We start with periventricular white matter hyperintensities. As their name suggests, these lesions sit right along the ventricular margins, and they can show as a thin cap of hyperintensity in the mildest form. So this picture shows a brain with periventricular white matter hyperintensities Fazekas 1. Whereas this image shows irregular hyperintensity extending deeper into the white matter, which represents the most severe grade, at least in our cohort. Moving to deep white matter hyperintensities, the mildest case is when the lesions show as small, discrete white spots. At the next grade, these punctate lesions start to become confluent and form larger patches. And in the most severe grade, we see full confluent lesions. The next marker we looked at is enlarged perivascular spaces. And under normal conditions, perivascular spaces are fluid-filled channels that surround small penetrating arteries in the, as they enter the brain. And they play an important role in metabolic waste clearance. But when they become enlarged due to small vessel disease, we refer to them as enlarged perivascular spaces. They appear as small, round, or linear hypointense structures on T2 images, or hyperintense on T2, or hypointense structures on T1 images. Visual rating is through counting distinct lesions in the slice that looks more severely affected. And based on this count, we assigned 2 scores, one for basal ganglia and one for the centrum seniovale. And here you can see 2 examples, one for each score. The next marker is lacunes, which are round or ovoid subcortical fluid-filled cavities. On T2 FLAIR images, they have a central hypointensity with a surrounding rim of hyperintensity. And their rating is based on presence, yes or no, if individuals have lacunes or no, or count. And the last marker we looked at is global cortical atrophy. And for this marker, we use the Vascular scale, which is widely used in neuroradiology. Basically, you scroll up and down, and based on the overall impression, you assign a number from 0 to 3. Again, with 0 reflecting no atrophy and 3 reflecting severe atrophy. And here you can see some examples. So after rating for individual markers, we also calculated the total cerebral small vessel disease burden score. So subjects would get 1 point if they had moderate to severe white matter hyperintensities and large perivascular spaces in radial ganglia, lacune presence, and moderate to severe global cortical atrophy. And based on this, each subject was assigned, again, a 0 to 4 score, with 0 reflecting no small vessel disease and 4 reflecting severe small vessel disease. And on this graph on the right, you can see the distribution of total small vessel disease burden in our cohort. And what stands out immediately is that almost everyone shows at least one marker of small vessel disease, with very few individuals having a 0 score. So the key message here is that small vessel disease is not a rare comorbidity in chronic post-stroke aphasia. It's actually highly prevalent. Now, in terms of our statistical approach, in order to examine how each small vessel disease marker relates to treatment outcomes, we ran a series of linear regressions. We ran one model per CSVD marker and one model that included the total score. In each model, the outcome variable was the change in treatment accuracy, calculated as the percentage improvement from pre to post-treatment. And we adjusted all models for key covariates, including stroke lesion volume, initial aphasia severity using the WAB-AQ, as well as age and education level. And this allowed us to isolate the unique contribution of each cerebral small vessel disease marker to behavioral gains. Here are the main findings. Starting on the left, we found that individuals with no or mild deep white matter hyperintensities, shown in blue, tended to show larger improvements in naming accuracy after treatment. In contrast, those with moderate to severe deep white matter hyperintensity, showed in red, demonstrated smaller gains. And looking at the middle panel, we see that this is the pattern is very similar when we looked at the effect of global cortical atrophy. And finally, looking at total small vessel disease burden, we found that individuals with a score of 0 or 1 tended to show the largest gains. So the key takeaway from this analysis is that individuals with higher vascular burden generally showed smaller treatment gains. So after seeing this pattern, the question we ask is why? What mechanisms could explain this link? So there are two main possibilities we considered. The first possibility is that of a direct effect of CSVD on language systems. Basically, small vessel disease affects the integrity of cortical and subcortical networks that support language. So individuals with more vascular injury might start out with poor baseline language performance. And if this explanation is correct, then CSVD severity should also correlate with baseline language ability. The second possibility we consider is that of an indirect effect on recovery capacity. Basically, cerebral small vessel disease compromises neuroplasticity, network adaptability, and overall brain's general resilience. So even if someone has the same baseline language level, their brain may be less able to take advantage of treatment. And in this scenario, CSVD might interact with broader cognitive abilities, which are also key determinants of recovery capacity. So our next step was to determine which of these two pathways better explains why vascular burden shapes treatment responsiveness. And for that, we used data from pre-treatment standardized assessments. Starting with the first possibility and baseline accuracy on the BNT by CSVD burden, what we actually found is a flat slope. So there is no meaningful relationship. It's not the case that individuals with high CSVD individuals with high CSVD have worse naming at baseline. And the same was true for semantic processing and baseline performance on the pyramids and palm trees task, as well as aphasia severity. And just to note, this pattern holds across all individual small vessel disease markers. Here I'm showing the plots just for CSVD burden, the total score, but this is the case for all individual markers as well. So this first explanation, that of the direct effect of CSVD on baseline language abilities, is not actually supported by our data. Turning to the second possibility, here we see a different pattern. This plot shows the relationship between total CSVD burden and baseline nonverbal executive function measured using the CLQT composite score. And unlike what we saw for language, here the association is significant and negative. Individuals with higher CSVD burden had lower executive function scores. And this was not specific to the total score. When we looked at individuals' small vessel disease markers, we found very similar effects. We found an effect of periventricular white matter hyperintensities, deep white matter hyperintensities. Actually, the effect there was even stronger, and lacunes. So unlike language measures, what we found is executive function is systematically related to cerebral small vessel disease severity, supporting our second possible interpretation. Now, to make sure that whatever we found in this cohort is actually true, we tried to replicate everything in an independent cohort. So with that, I'll move on to the next study, which uses data from a recently completed R01 awarded to Drs. Kiran and Fedorenko. And a few details about our cohort. We collected data from 44 individuals with post-stroke aphasia. There's a typo there. I used the same icon as before, but I forgot to change the number. So our subjects are 44. The majority of them were male, aged between 50 and 64, so slightly younger than the previous cohort. And they had, again, various levels of education. In terms of their aphasia characteristics, all participants were in the chronic phase, with the majority of them being more than 5 years post-stroke. They had mild aphasia per the WAB-AQ, and apart from behavioral assessments, 34 individuals also completed neuroimaging procedures, and using data from the structural MRIs, we were able to assess for small vessel disease as well. Now, for the second study, we collected data from a single time point, but we used a much more comprehensive assessment protocol. Our goal here was to capture a wide range of linguistic and non-linguistic cognitive abilities. So the battery spans classic aphasia measures, semantic processing, comprehension, memory, attention, executive functioning. And here you can see most of the tasks that we administer. We administer more, but here I'm presenting what is relevant for this analysis. So this protocol gave us a rich multidimensional behavioral profile for each individual. And as part of our planned analysis, my good colleague Anne Billot performed a principal component analysis. to reduce the dimensionality and extract data-driven components. And you can find details on plan analysis in her OSF preprint. Now, the principal component analysis revealed two meaningful behavioral components. The first one loaded strongly on core language measures, including naming, repetition, auditory comprehension, reading, spontaneous speech, and language-related scores from the R-bands and the WAB. So we interpreted this component as capturing linguistic abilities. The second component loaded most strongly on tasks tapping visual-spatial processing, nonverbal semantic processing, and working memory. So we interpreted this as reflecting general cognitive abilities. Similar to the previous study, we characterized small vessel disease in collaboration with Dr. Andreas Karidimou, the neurologist who helps with these neuroimaging projects, and J.D. Kurtz, who conducted her master thesis with us. Similar to the previous study, we evaluated white matter hyperintensities, enlarged perivascular spaces, and lacunes. And here for this cohort, we also had susceptibility weighted imaging, SWI, available for all the participants, which allowed us to assess a very meaningful and important small vessel disease marker, namely cerebral microbleeds. Briefly, cerebral microbleeds are small chronic deposits of blood-derived iron that accumulate in the brain following leakage from fragile small vessels. They appear as small, round black lesions, usually 2 to 10 millimeters, and similar to lacunes, rating was based on the presence and actual count. We also calculated the total small vessel disease burden score following a similar procedure as the one described previously. So let me walk you through the results for this second cohort. First, looking at the distribution of total CSVD burden in this sample, most participants had relatively low levels of small vessel disease. And just a note, these are younger participants overall. So a substantial number had a score of 0 or 1, and only a few individuals showed more pronounced CSVD. So overall, this cohort is on the milder end of the CSVD spectrum. Following the same logic as in our previous studies, we first asked whether CSVD burden shows any direct relationship with linguistic abilities. Here you can see the relationship between the total CSVD score and aphasia severity. Basically, there is no evidence for an association. Individuals with higher CSVD burden did not actually have worse aphasia profiles. And when we looked at whether CSVD burden was linked to the linguistic component we derived from the PCA, again, we found no association. And of course, we repeated the analysis with individual markers, and the results were the same. Now, when we turn to general cognitive abilities and the second component we derived from PCA, we begin to see a different pattern there. So for periventricular white matter hyperintensities, we found a moderate negative association with the second behavioral component. So individuals with more periventricular disease tended to have lower general cognitive scores. For deep white matter hyperintensities, the trend was similar, although the association did not reach statistical significance. So overall, this mirrors what we observed in the previous cohort. Basically, CSVD seems to be related with non-linguistic cognitive abilities rather than language abilities per se. And going back to the two mechanisms we proposed earlier in this independent cohort, we were able to replicate the same overall pattern. Now, the last data that I will present from this cohort actually takes advantage of a unique feature of this data set. So as I said before, because we wanted to assess different domains of cognitive abilities, these participants also completed 2 nonverbal theory of mind tasks. And Jade analyzed this data as part of her master thesis, which allowed us to examine whether CSVD burden also affects social cognitive abilities in aphasia. Now, the topic of theory of mind abilities in post-stroke aphasia is relatively understudied. Most of the existing evidence comes from small scale studies showing basically no difficulties in theory of mind in individuals with post-stroke aphasia. So there is still very little systematic work on how theory of mind behaves more broadly in aphasia, and no evidence on how it might be influenced by small vessel disease. And in the interest of time, I won't go into all the task details. I will briefly describe them so you can get an idea of what participants had to do and how we assessed this ability. So we used 2 nonverbal false belief tasks developed by Birvoy and colleagues. Both rely on short, silent video clips, and one of them, the reality known, is intentionally more challenging because it places greater demands on inhibitory control. And just to give you an idea of how the false belief trial works, in the reality unknown low inhibition task, the easiest one, at the beginning of its video, participants can see a man hiding a green object in one of these 2 boxes. The man shows to the woman sitting next to him where the green object is located, but the participant cannot actually see where the green object is. Then the man covers the boxes and the woman leaves the room. And during her absence, the man swaps the boxes. So the woman comes back in the room, sits down, and puts the pink object on top of one of the boxes. At that point, the video is stopped and participants have to point to the box which contains the green object. And to answer correctly, participants have to understand that the woman has a false belief about the location of the green object. Now, in the reality known or high inhibition task, which is slightly more difficult than the other one, at the beginning of the video, the man places the green object in one of the 2 boxes, but this time, both the woman that sits next to him and the participant can actually see the action of placing the object. Again, the woman leaves the room, and during her absence, the man will take the object out of one box, will put it in the other. Then the woman returns, sits down, and looks at a neutral location in the middle of the 2 boxes. And the video is stopped, and participants are asked to point to the box that the woman will open first to find the green object. And in this case, they will have to inhibit their own background knowledge and assign the false belief to the woman. So very briefly, here are the main findings from the behavioral aspect. So what we first observed that theory of mind deficits actually exist in a notable proportion of participants. And even though this cohort was predominantly mild, quite a few people had challenges with these tasks. Second, as you can see in these scatter plots, theory of mind performance was not associated with aphasia severity. In other words, individuals with more preserved language abilities were not necessarily the ones who performed better on these tasks, and the other way around. So even in mild aphasia, theory of mind challenges are present, and they appear to be independent of language impairments itself. So the natural question for us to ask was, if theory of mind difficulties do not stem from aphasia per se, could they be tied to the underlying small vessel disease? And this is what we looked at next. And the answer is yes, there seems to be a negative association between theory of mind processing and severity of cerebral small vessel disease. Specifically here, you can see the associations between enlarged perivascular spaces in the basal ganglia and performance on both theory of mind tasks. So as the severity of enlarged perivascular spaces increases, overall accuracy on both tasks decreases quite substantially. We also found negative associations with a number of cerebral microbleeds and lacunes. However, I want to be very transparent about the limitations here. The data are highly skewed, with the majority of participants having zero or very few microbleeds or lacunes. So although the pattern is consistent with what we observed for enlarged perivascular spaces and the effect was statistically significant, I would not go to the bank with these plots just yet because the regression lines may be disproportionately influenced by the very few severe cases that we had. So let me pause here and summarize the key insights that have emerged so far. First, recovery from aphasia does not happen in isolation. It unfolds within a broader neural ecosystem. It's shaped not only by the focal stroke lesion, but also by the health of the surrounding brain. The second insight is that cerebral small vessel disease is very common among individuals with post-stroke aphasia. It's part of the background architecture that many of our patients bring into their recovery journey. Third, across independent cohorts and different analytic approaches, we see a consistent pattern. Greater CSVD burden, whether we quantified it using total burden score or individual markers, does not seem to directly affect language abilities. On the other hand, it is associated with poor non-linguistic cognitive abilities and reduced responsiveness to therapy. Finally, some emerging findings suggest that the effects of small vessel disease may extend beyond traditional cognitive domains and into areas like social cognition. And again, one more question for us to ask: why do these matter? How do we bring all this together into a model that actually helps us understand and ultimately improve recovery in aphasia? This leads us to our proposed framework, which I think best captures what these results are telling us. It's work in progress. I have several ideas that I can implement and actually test this framework. The core premise is very simple. By now, I said it multiple times. Aphasia recovery is something that takes place in this broader system. And on one side, we have the stroke lesion, whose location and size determine what functions are impaired and how severely impaired they are. And this is the part of the story that we already understand very well. But our data also suggests that cerebral small vessel disease, which is a proxy of brain health, is another important determiner that shapes the brain's capacity for plasticity. And thinking about the mechanism behind this relationship, the hypothesis we're working toward is that we don't think that CSVD affects language recovery by directly damaging language circuits. Rather, the relationship appears to be indirect. Small vessel disease compromises white matter pathways and disrupts the coordination of distributed networks that support the cognitive processes people need to benefit from therapy. And that brings me to the next steps. So at the Center for Brain Recovery, part of our work is anchored in 3 pillars: detect, treat, predict. And I would argue within the next few minutes that I have left that brain health can and should be fully embedded within each of these pillars. So starting with detect, one of the clearest lessons from today, I hope, is that cerebral small vessel disease is both common and under-recognized in people with post-stroke aphasia. If we don't measure it, we miss an entire dimension of brain health that shapes recovery trajectories. So at the detection stage, integrating vascular screening into routine assessment can help us uncover contributors to variability that are otherwise invisible. And this means that by quantifying CSVD burden early and combining this information with multimodal cognitive data, we can ultimately refine diagnostic precision so that we can identify individuals who may need additional support long before they begin to fall behind in therapy. Treat is where the implications become even more actionable. So if CSVD affects domain general systems, then treatment needs to be calibrated to the person's cognitive capacity, not just their linguistic profile. So this could mean tailor the intensity or structure of therapy when cognitive resources are limited, and incorporating treatment protocols that target domains other than language, such as attention. And just a thought for neuromodulation studies, these insights suggest an additional layer of caution. Even when stimulation targets areas far from the stroke lesion, the underlying tissue may still be compromised due to small vessel disease. So we may want to start controlling for these into neuromodulation in our neuromodulation protocols to optimize stimulation parameters. Finally, predict is the area where incorporating CSVD burden has the greatest potential to change what we do and how we do it. So if CSVD indexes the brain's plasticity potential, then it becomes a critical variable or feature in predicting who is likely to improve with therapy, how fast, and what kind of support they may require along the way. And because CSVD is not only a marker of current brain health, it is one of the strongest predictors of long-term cognitive trajectories. Incorporating vascular brain health markers into our prediction models may also help us identify individuals at risk for future cognitive decline or dementia. So this creates an opportunity for earlier counseling, monitoring, and targeted prevention strategies. So if recovery depends on both damage and resilience, which I think it does, then our job is to measure both, because only then we can empower people to reach their fullest recovery potential. So with that, I would like to end my presentation. Thank you for your attention, and I'm ready to answer your questions.
Thank you so much for a great talk, Maria. We can see that room applauding for you.
Thank you.
We do have several questions, some in the chat and maybe some from the room. So maybe we can start by taking questions in the room, if we have any. I'll get us started with one, which I think echoes at least one question in the chat. I'm just wondering, your results overall seem to suggest that cerebral small vessel disease is associated with cognitive measures to a greater degree than linguistic measures or measures of aphasia severity. I need to speak a little bit about that, but assuming that there is a correlation between cognitive measures that we typically collect in people with aphasia and linguistic measures that we also assess, can you speak a little bit to whether you have an idea for a mechanistic explanation for this discrepancy, if that makes sense?
It does make sense. And actually, I don't think that this is a discrepancy. This is exactly the mechanistic explanation that I give for these results. So think about it as a mediation analysis, right? We know, let's say that, maybe not a mediation analysis, I'll take that back. We know that non-linguistic cognitive abilities are correlated with language abilities. And we know that small vessel disease markers correlate with non-linguistic abilities. So the mechanism that I'm proposing is that small vessel disease affects language recovery, not because it's correlated directly with language abilities, but because it goes through the domain general cognitive abilities. So I don't know if that answers your question, but I think that that's the beauty of these data. It's not that everything correlates with everything. There is, to my understanding, a meaningful lack of association between small vessel disease and language abilities, and then a meaningful strong association between small vessel disease and non-linguistic abilities that we do need in order to recover.
Oh, that makes sense. Thank you. All right, so we have a couple of questions in the chat. The first from Maria Ivanova. She says, Maria, thank you for a great and very clear talk. This is obviously a greatly overlooked factor contributing to recovery trajectories. I wanted to learn more about CSVD prevalence and evaluation. Which CSVD markers or features are most common in this population? Is there a typical progression of these features? Do some tend to appear earlier than others? And finally, do you have longitudinal data that might shed light on how these changes evolve over time post-stroke?
Okay, that's a great question. So let me start with the prevalence of small vessel disease. As I said at the very beginning, this is a very common disease. Eventually, everyone will get it, but not everyone will have symptoms, and it's associated with aging. It's a cause of stroke and vascular cognitive impairment, dementia, and ADRDs. And that literature is pretty rich. So there is evidence that all of these markers are associated with cognitive outcomes or stroke outcomes, recovery trajectories. So that's a very rigid literature. What is happening in the aphasia literature, let me go back to the other part of the literature, the stroke literature and the preclinical literature. So basically, most of those studies excluded individuals with post-stroke aphasia because they couldn't perform the task, or because of the communication barriers. So that's why our subfield in the aphasia field is very young and very, very limited. Many aspects on this question. So about the prevalence, I think I responded. It's something very common. So different markers have been associated with different cognitive outcomes. It's not the case that we have someone that is a winner here, but I would say that the one marker that is that we do see in medical records quite often, and therefore most of us are familiar, is white matter hyperintensities. But in the dementia world and stroke literature, most of the markers are used. That's why I decided, since I had the right sequences, to look at the whole spectrum of CSVD. So it's not that there is one marker that is more prevalent than others. What was the other aspect of the question? Whether I have longitudinal data?
Yes, whether you have longitudinal data that might shed light on how these changes evolve over time post-stroke.
So cerebral small vessel disease is a progressive disease. So I don't have longitudinal data myself yet, but the literature that is out there shows that people progress over time. And a lot of people who develop small vessel disease, eventually they will convert to vascular cognitive impairment, dementia, Alzheimer's disease, and related dementia. So, and that's why I'm saying that we need to start incorporating these features into our prediction models, because eventually we can catch early on individuals with post-stroke aphasia that will eventually develop dementia as well, and help them with more targeted therapies.
Perfect, thank you. We do have one more question in the chat box, but I do have a question that is sort of piggybacking off of the question that you just answered. I wonder, have you looked into the relationship between this lesion factors and CSVD? So does the lesion itself, its size, its location, predict worsening of CSVD, or is it the other way around, that those individuals who had pretty bad small vessel disease to begin with, those were more likely to go on to have a stroke? Does that make sense?
It does make sense. So all the data that I presented today are data from people who are in the chronic phase. So I cannot really tell whether their stroke was due to small vessel disease, or whether the small vessel disease that I'm seeing is something that happens independently of their stroke, or as part of aging, as part of other pathologies such as Alzheimer's. So I cannot really answer that question, because my data are from the chronic phase, and I don't have small vessel disease data from their acute phase. The other part of your question was
basically whether the stroke leads to more.
Yes. Oh, yeah. I forgot to add this slide, but for the second cohort, Jade actually looked at the association between stroke lesion and small vessel disease, the stroke lesion size, and we didn't find a strong association there. Another thing I should mention is that when we rated those small vessel disease markers, we only focused on the right hemisphere, because we didn't want to have, the effects of stroke on the rest of the left hemisphere. Of course, most of these lesions are symmetrical and bilateral, but we think that whatever effect we see is on top of the effect of stroke lesion. And that's why we wanted to include stroke lesion in the models as well as a covariate.
Perfect, thank you. We got one more question in the chat from Kirana Sapkini. Very interesting talk, Maria. Is it only by visual inspection that we can evaluate white matter hyperintensities? Can we distinguish between chronic and acute, or due to stroke changes, or should we assume that all changes are chronic? And why do you think that white matter hyperintensities are related to theory of mind, but not to aphasia severity, if I understood correctly?
Okay. Again, you may have to help me with all the components. So maybe I can take a look at the chat as well. Okay. Yes, it is. So what we did for our studies, we followed the typical protocol that a neuroradiologist would use. So we used the visual rating scales, very old-fashioned, and but we wanted our approach to be as close to the clinical practice as possible. As I said before, white matter hyperintensities are something that we typically see in the medical records of our participants. So we can easily incorporate these measures if whatever associations we find is based on what a neuroradiologist would do. So that's, but of course there are methods that allow us to do more fine-grained analysis, like volumetric methods. Can we distinguish between chronic and acute? I think I answered this question as part of the answer I gave to Sigfus. Since we only see participants in the chronic phase, I cannot really speak to that. I assume that because these people suffered a stroke, they also had some small vessel disease even before their stroke, but of course it started accumulating over the years. And then why do I think that white matter hyperintensities are related to theory of mind, but not to aphasia? And again, this speaks to how I think about small vessel disease in the context of aphasia. I don't think of small vessel disease as a contributor to aphasia. I think about it as something that is a comorbidity. It takes place in parallel, and it makes life more difficult, I guess, because of all the other domains it affects. One thing to note is that for theory of mind, I found a stronger association with enlarged perivascular spaces in the basal ganglia, and there is literature suggesting a role of the basal ganglia or the health of the basal ganglia in theory of mind and social cognition in cases or diseases like Huntington's disease, Parkinson's disease, and other conditions. So that's my short answer, I guess.
Perfect. Thank you so much. I think that's the rest of our questions. So that would bring us to the end of today's talk. Thank you so much, Dr. Varkanitsa, and thanks to our online audience for watching and asking questions. And we look forward to seeing you again in not 2 weeks' time, 3 weeks' time for another C-Star lecture. Thank you so much.
Bye. Thank you very much. Bye.